So now we have Dr. N. Sandhya, who's going to talk about challenges in phacoemulsification after vitreoretinal surgeries.
Thank you, Dr. Nina. So, preoperative considerations. All patients should have a careful slit lamp examination to look for any pre-existing posterior capsule rent which can arise from trauma of the previous surgery. Biometry should be accurate in these patients, and ideally, if available, optical biometry should be done. And optical biometers have a silicone oil mode for eyes filled with silicone oil, and newer ultrasound biometers also have this silicone oil mode for IOL power calculation. All patients should be informed about the guarded visual prognosis before surgery itself because of the underlying retinal pathology. Now, coming to intraoperative consideration, this patient had undergone pars plana vitrectomy in the past, and you can see the conjunctival scars corresponding to the previous surgery. Pupil was dilating well, and the nuclear sclerosis was grade 2 to 3. Trypan blue was used to stain the capsule, and you should never make a baby size rhexis in these patients because these patients already have a deep anterior chamber and there will be difficulty in pulling out the nuclear pieces. And the rhexis should also overlap the IOL optic all around. The posterior capsule in these post-vitrectomized eyes are vulnerable for posterior capsule descents. Hence, the hydrodissection should be very gentle. Now, these vitrectomized eyes, the vitreous gel is replaced by fluid. So, there is no gel support for the eye and for the cataract. So, the cataract is at the deeper plane and the anterior chamber is deep in these eyes. So, whenever you are introducing phaco probe, the infusion pressure should be lowered so that there is no sudden deepening of anterior chamber which can cause pain to the patient and also will make the nucleus manipulations difficult. So, you need to reduce the infusion pressure. So, when you reduce the infusion pressure, there may be collapse of the anterior chamber. So, proportionately, we will have to reduce the aspiration flow and vacuum. So, during cortex removal also, we need to reduce the infusion pressure and aspiration flow rate. So, after this, a single piece lens was placed inside the bag, and whenever there is doubt on the integrity of corneal tunnel, you can put a suture there. So, these eyes, because of the low scleral rigidity, they are more prone to what is known as lens iris diaphragm retropulsion syndrome. Here, whenever the eye is filled with OVD or when we are starting the infusion, the iris is thrown back onto the anterior capsule. There is 360-degree iridocapsular contact, which can lead to reverse pupillary block, and this will lead to sudden deepening of anterior chamber, stretching of ciliary body, and can cause discomfort to the patient, more so if they are operated under topical anesthesia. So, we can reduce the infusion pressure when you are introducing the phaco probe to reduce this. And this can happen at any time of surgery, that is even during the cortex removal. And you can lift the iris off the anterior capsule using a Sinskey hook so that the fluid equilibrates between the anterior and posterior chamber, and the iris and the anterior chamber, they come back to their normal position. So, this patient had undergone pars plana vitrectomy with silicone oil injection earlier. So, as you can see here, when the rhexis was initiated, the lens started moving, and also there was great difficulty in initiating and continuing the rhexis, which indicates generalized sonual weakness. So, when hydrodissection was done, you can see large coming through the sonules because of the weakness, and this much amount of oil is quite uncommon during cataract surgery. What we usually see is this, that is emulsified silicone oil bubbles in the anterior chamber, which can be easily washed off or can be removed with injection of OVD. So, since this was a soft cataract, so you can see the oil still coming. It was prolapsed into the anterior chamber, and after protecting the endothelium with dispersive OVD, this was emulsified in the anterior chamber using low phaco parameters. Then the cortex was removed by pulling it tangentially rather than radially, so that there is less stress on the sonules, and then bag was filled with OVD and a CTR was inserted. So, this CTR gives equatorial support to the capsular bag, and it uniformly strengthened the sonules. So, once CTR was inserted, once this was inserted, the oil stopped coming. So, because it is strengthened by the CTR. So, after this case was handed over to VIA surgeon for oil removal. Now, the cataract in these eyes tends to be typically of nuclear sclerotic type, and they will have a leathery texture and a hard endonucleus. So, the clear corneal tunnel should not be too long because already the anterior chamber is deep in these vitrectomized eyes. So, in that case, if the clear corneal incision is long, you will have to hold the instruments more vertically, which will cause difficulty during the nucleus manipulation. And also, you should chop the nucleus into multiple pieces, and then after protecting the dispersive OVD, you should emulsify these pieces using low ultrasound energy so that there is less damage to the corneal endothelium. So this patient had a near total cataract and he had already undergone silicone oil injection. You can see the posterior capsule plaque here, which is not very uncommon in these oil-filled eyes. You should never try to remove this through the anterior route, which can cause posterior capsule dehiscence. So this can be removed by the pars plana route during oil removal, or this can be YAG lasered later. And then this posterior capsule in these eyes filled with silicone oil, they have appear to be thickened and they'll have a sheen-like appearance. Now this patient had undergone vitrectomy earlier and the pupil was not dilating well. During phacoemulsification, you can see there was billowing and fluttering of iris and there was progressive intraoperative meiosis, which are signs of intraoperative floor P-iris syndrome. So once the phaco parameters were reduced, the fluttering and billowing reduced and the chamber became stable, and we could safely complete phacoemulsification in this patient. Not dilating well, there was posterior synechiae, and there are silicone oil bubbles under the conjunctiva here. These are the silicone oil bubbles under the conjunctiva. So after injecting OVD, the posterior synechiae were released, and here iris hooks were used to provide visualization during cataract surgery. So coming to postoperative considerations, all these patients should have a thorough retina checkup postoperatively and refer to the vitreoretinal surgeon for the follow-up of their underlying retinal problem. So to summarize, a thorough preoperative evaluation is needed to look for any phacodonosis or pre-existing posterior capsule rent. These patients are more prone to lens iris diaphragm retropulsion syndrome. So whenever you're using phaco probe, the infusion pressure should be reduced. They should not have a too long corneal tunnel, should not make a baby size rhexis in these patients, and hydrodissection should be careful. Don't try to remove the PC plaques through the anterior route during cataract surgery. And all these patients should preferably have a postoperative retina evaluation. Thank you.
Thank you, Dr. Sandhya, for those excellent demonstrative videos. I have a question. Maybe it is stupid, but what do you have any IOL preferences when you do surgery? The type of IOL, single piece or multi piece? Because once or twice, when I've done pediatric cataract surgery, we had a patient with PHPV, and I'd put a single piece in the bag, and the VR surgeon had to go from behind and do the cut the plaque. The single piece just came out. So now I just make sure that you always use a 3-piece lens.
I don't think there's a preference for lens in these eyes,
because
but silicone lenses should be avoided in these patients. Otherwise, for cutting plaques, I'm not aware of any lens preference. Preferably, silicone lenses are avoided.
Yeah. Any comments, Dr.
Anil?
Same thing I would say. For adults, I don't think it matters, man, because they can make a small cut with a vitrector. They can make a 3 mm opening. But in a pediatric, the pressures are different when the capsular fibrosis happens. And maybe in such patients, this single piece is not a good option.
Yeah, I always feel 3-piece has a better memory, and I think when you're expecting some fluctuations.
Yeah, then thing is this single piece lenses, the haptics usually unfold in a controlled manner. So, but 3-piece lenses, see, you should be very careful while injecting these lenses. And also, see, if there are high-risk cases, it is better to have a backup of 3-piece lens, because if there is any PC rent which is unexpected, then you can place the lens in the sulcus and do an optic capture.
Okay, thank you.
One small question. See, in a lot of patients, the VR surgeon tends to keep the oil because they have a like long-standing RD. So you have to make the necessary calculation.
See, actually, in these ones, we have the silicone oil mode. Actually, see, newer optic ultrasound biometers also have the silicone oil mode. You can just calculate with that mode for these patients. Madam. What? +3.
Yeah.
Yes, sir. 0.721. What we are getting.